This is Avnish Tripathi. I'm a first-year cardiology fellow at University of Louisville. And Dr. Butler, thank you so much for giving the time for us. Sir, Kunal asked you about the heart failure-associated questions. I will ask more about the mentoring. So you've been such an influence in the field of heart failure, and many of our colleagues are interested in heart failure. At this stage of our life, heart failure is a proliferating field. I think the research is one of the most exciting researches coming out. We've got LVADs, we've got transplant, we've got a lot of medical therapy as well, and cardiomems, those kind of things are going on. So from a research point of view, for young people, any suggestions of how they should try and focus and how will that help later on in their career?
Well, so one, you're too kind to ask me to talk about these issues, and I appreciate the opportunity. I think we are living in a very sort of an interesting era right now. So one is obviously, as you said, heart failure is not going anywhere, and heart failure is sort of, in a way, you can say is the sort of the last unconquered field in cardiology, right? Yes. So if you look at the outcomes for stroke and arrhythmias and myocardial infarction and coronary disease, we have made much more progress. If you come to heart failure, the population is aging, the prevalence of heart failure will go up. It's not going to go down. Right. And then on top of that, although we have made significant strides in patients with heart failure, reduced ejection fraction, still there's a lot of residual risk, but 50% of the patients have HFpEF, for which we have absolutely no therapies. Right. And all these issues that we discussed about readmission when people come into the hospital for decompensated heart failure, they are at a 30% risk for mortality within 1 year of discharge. Right. And for the past 20 years, we've done a whole bunch of trials, and so far we still don't have an intervention to reduce the outcomes post-discharge. So there's a ton of work to be done, right, and there's a ton of patients who it's not going well, right, going anywhere per se. So great time to be involved. Now, in terms of clinical trials, if you look at pharmacotherapy, if you look at systems of care, if you look at devices, there is just an unbelievable amount of research going on in this field. So it's a very exciting time. And also the good thing is that in this day and age of sort of the media-driven sort of environment that we live in, if you want to get involved in research, you don't have to have a local mentor. So when I was your age, 100 right, years ago, one of the advice that we were given is that when you choose your fellowship, make sure you choose the fellowship at a place where you have a mentor who can work with you. Right. I think in general, you cannot overemphasize the importance of mentor. There is right, nothing more important for a successful career than mentorship. But remember, it's a two-way relationship. If you are the world's best mentee, but the mentor is not interested, it's not going to work, and vice versa. Right. Having said that, in this day and age, your mentor does not have to be a local person. Right. I think the world has gotten a lot more closer through email, through internet, through teleconferences, through meetings like this. I know plenty of examples where distant mentorship have been very, very successful, and people are very open to involving young physicians who want to get involved in research. My recommendation is, if you want to get started, the first step is to get started with something. So both ACC and AHA, for instance, the Get With The guideline, have a track record of a lot of publication. It's a very open process. That's right. And that's where you start talking to some of the senior people in the field. You start writing with them. I would definitely, maybe you're a little bit earlier part of your career, but when you start becoming a junior faculty, definitely get involved in clinical trial. If you do 15 clinical trials and enroll 2 patients, it doesn't help. From a career perspective, do 1 or 2 trials, but be a high enroller and a good quality data provider, and you will get notice in less than 5 years, 3-4 years, and that's when things start to turning, and then all of a sudden you're part of some of the committees of the trial, and then you kind of just go from there. So I would say start with databases, talk to people, what opportunities are there, get involved in national research, and when you complete your training, become a junior faculty, get involved in clinical trials, but be a robust enroller in the clinical trial, and it will take it from there. Now, if you have niche interest, if you're doing your PhD or in some basic science lab, that's also a very good track to go to. But what I'm talking about is for most of the clinical researchers that are out there, that this is a path that I have followed and a lot of people have successfully followed.
Right. So thank you so much. This is such a good piece of information and advice. I mean, both from the mentoring point of view and from clinical terms as well. So before you go, can I ask just one last question?
Yes.
And this is sort of sort of a funny question, but if you were to do your fellowship all over again, would you still choose heart failure?
Oh, absolutely. No, doubt about it. In fact, I would choose it even more. Remember that when I did my heart failure fellowship, I spent 2 years in John Wilson's lab at Vanderbilt, and at that time, it was either transplant or Lasix, right? I mean, it was a very different era, but now we have ABIM boards in heart failure. It's a bona fide specialty. The LVAD and the device world has sort of taken up. So if there's any time to do heart failure, it's today.
It's now. Thank you so much.
Great.
Sir.
Thank you so much.
I appreciate your time, sir.
Really appreciate it.